Okay, good afternoon everyone. So today we are going to cover completely esophagus and diaphragm with respect to our surgery point of view. Okay, so let's begin our lecture. So what today we are going to just cover only question and answer part. Okay, so we will study question answer wise. So first, what type of question to be asked from diaphragms? Okay, that may be either diaphragmatic hernia, congenital diaphragmatic hernia, also called a hiatal hernia or acquired diaphragmatic hernia, paraesophageal hernia and sliding hernia. Okay, remember what the important point to be remembered are there are two type of diaphragmatic hernia, that is either congenital as well the acquired. Okay, and sliding hernia is also further two type, that is either diaphragmatic hernia as well the inguinal hernia. So we have to read the question above carefully. Okay, first of all, okay, so as I told that it is of two type, either congenital or acquired. Okay, congenital is further of two type, that is Morgagni as well the Bodlek hernia. So starting first is our congenital hernia, that is two types. So look here, this is if the diagram, and this is the crura part of the diaphragm, this is anterior side and this is posterior. So the Bodlek hernia occur in the posterolateral side. Okay, this is posterior side as well, this is lateral. So in this direction, in the posterolateral side, whereas the Morgagni, or also called a right anteromedial or presternal hernia as well the Lery's hernia, where the prime main content is our transverse colon. Okay, in it occur in the direction of the anteromedial part here. Okay, so this is the most common site for the Morgagni hernia as well, and this is the most common site for the our Bodlek hernia. Next is how we will remember it. So as we know that Bodlek is most common in the left and the posterior side. Okay, so we will remember it as a BPL, that is Bodlek occur in the posterior and the left side, whereas the right anterior side Morgagni hernia will be occurring. So what is the incidence rate? Out of the 5,000 live birth, where the most common, overall the most common among the above is left posterolateral. Rarely it occurs as a bilateral. So what is the etiology? Okay, simply there is the defective in the closure of the pleuro peritoneal canal. By the time during the closure of the diaphragm, if there is be defect, there will be defect, then this type of hernia will be occur. So next is the as due to the failure of the pleura-peritoneal canal, as a result abdominal content will be herniate, resulting in the defective of the causing the above condition. So what is its pathology, pathophysiology, how it occurred? Listen, compression of the lungs cause the pulmonary hypoplasia, which is bilateral. Okay, simply you can understand that if this is diagram, this is lungs as this is diaphragm. If there will be herniation or there is a defective opening, so what will happen? The content present here will try to push push or compress the structure of our lungs, resulting in the poor formation or defective formation of the lung, causing hypoplasia of the lungs tissue. है ना? That's called shown that compression of lungs will cause the pulmonary hyperplasia, that it will be bilateral. Rarely it will affect the ipsilateral side, and also cause of the pulmonary hypertension is due to the increase in the medial muscle thickness of the arterial wall. Okay, what is the clinical feature, how the patient will present with? So we will remember it just by the single word, that is RDS. What is RDS? Simply we know that RDS is respiratory distress syndrome. So what here the RDS is? R for respiratory distress, that our mnemonic, and D for dextrocardia, and S for scaphoid abdomen. This is the clinical triad of the finding. Okay, and other symptoms are dyspnea, cyanosis, infant with the chest retraction due to abnormal structural formation. Okay, so next how we will investigate? For investigation we will go for prenatal USG, and that will be shown. And as we know that gas bubble, where gas bubble we see in case of the perforation, where the gaseous part will shown in the X-ray as a dark color. So here also same condition will be seen when the intestine will herniate through the diaphragm. So in the X-ray we can see that if this part is diaphragm and this is the lungs, and here the if the intestine or the bowel will move here, then the gases present in the bowel will appear as a dark. Okay, so that want to explain that postnatal x-ray will show that the gas air bubble in the chest or the bowel loop in the chest. Okay, next is the pneumothorax can also occur on the opposite side of the congenital diaphragmatic hernia. So okay, just summarize the above what we have studied. First we have studied the congenital hernia, that is of the two types, congenital as well the acquired. And congenital is further of the Bordlake and the Morgagni. Bordlake is in the direction of the posterolateral, whereas the Morgagni is in the direction of the anteromedial. And mnemonic we remember that is BPL, that is Bordlake occur in the posterior side as well the left. And what is the etiology of causing? It will cause the cause due to the failure of the pleura peritoneal canal closure, failure of the its poor closing. And next is its pathology. What it will cause? It will cause and compress the lungs, resulting in the pulmonary hypoplasia. And after that, clinical feature, it should be diagnosed by the prenatal. And next is in the clinical feature, our mnemonic is RDS, that is respiratory distress, dextrocardia as well the scaphoid abdomen. Okay, other feature like cyanosis, chest retraction, and the dyspnea also present. And after that, for investigation, we will go with the prenatal USG and the chest X-ray, where the gaseous bubble is seen, and the pneumothorax on the opposite side of congenital hernia. Okay, it's all about just basic how the hernia will occur and how its etiology as well the pathology. Now we will go with the management, that is our the one of the most important part. Okay, so let's begin our management part, that is treatment of the hernia. When the diagnosis, when we diagnose, after diagnosis, that if in case of the prenatal, open fetal surgery as well the fetal tracheal occlusion is being evaluated as a treated opinion. In this, the fetus is kept attached to the umbilical cord for half an hour, allow the surgeon to perform the ex utero fetal surgery for the various conditions. Postnatally, the first priority is to stabilize the respiratory syndrome. Okay, and after that, early surgery without respiration stabilization aid to the physiologic compromise, and it's not recommended. So simply we as you know that after the birth of baby, the most important to manage is their respiratory function. But if there will be hernia and content of the bowel if disturb the function of the lungs, there will be difficulty in the breathing. So before cutting of the umbilical cord, we first maintain the respiratory function of the baby, so that either by the removing of the tracheal occlusion or either whatever tracheostomy, whatever required to be done. Okay, and after that, this is just simple after. So the first step of management is we will look here that in initial management, gentle ventilation with the permissive hypercapnia and a stable hypoxemia is better management option associated with the higher survival rate. Okay, so here we focus on only two things, that is first the permissive hypercapnia as well as second is stable hypoxemia. Okay, that will increase the chance of the survival. And other other way are, if the child has the indication of the ECLS, that is extracorporeal life support if required, then ECLS should be initiated. And the for the congenital diaphragmatic hernia, repair should be done after the completion of ECLS therapy, and the ECLS is given giving respiratory and the cardiac support outside baby to the newborn when his own organ cannot be fulfill the requirement, as the extracorporeal support will be provided that will help the baby to for their maintaining the respiratory function as well the cardiovascular function. Once the respiratory condition is taken care by above measure, the infant is operated after. Okay, then after 1 to 3 days we will just operate that. Okay, next condition is operative stage of the importance. What are the operative stage? First, what we will do on that operation? Viscera are reduced into the abdominal cavity, and the hernial sac, if it is in the large size, then should be excised and should be cut out and removed. And defect closed primarily using the mesh, and the aim is to tension free. So as we do on the hernia, normal hernia, that is either tension free repairing, same will be done here also. Okay, so what are the factors that affect the prognosis? First, most important prognosis factor is our pulmonary hyperplasia. Okay, and also it may cause the pulmonary hypertension too. And after that, risk of the bleeding and the complication with the ECMO is more common in the infant. Obvious it is occurring in the low birth weight child. And the other prognosis factor are the need of ECMO, polyabdomination, and size of the defect. Okay, so it's just generalize what we have studied till. We have just covered the complete topic of the congenital hernia. Now we will go for the acquired diaphragmatic hernia as well the hiatal hernia. Okay, it is as I have told, it is of two types. That will be three types. That is sliding hernia, rolling hernia, as well the mixed and paraesophageal hernia. So what is sliding hernia? It is the most common overall, and this is an upward displacement of the gastroesophageal junction into the posterior mediastinum. Okay, gastroesophageal junction will be just move upward, resulting in seen to occur more with the short esophagus and a patient with inguinal hernia. And the size correlate with the severity of symptom. It's all as we know that in short esophagus syndrome, it's the stomach and stomach part and the esophagus part. Whatever as the size of the esophagus decrease, the lower structure like stomach will be pulled upward, causing the above condition. Okay, second one is the rolling, or also called a true paraesophageal hernia. This is more common in the female, and here the gastroesophageal junction is normally positioned with upward herniation of the stomach anterior to esophagus, and as posterior gastroesophageal junction is fixed normally. Okay, so what will happening here, that in the if let this is part is called diaphragm, and this is our stomach part, and this is part is called our esophagus. So what will happen, that the anterior most part of the stomach, that this part is pulled upward. Okay, so not here the not esophagus is moving, just stomach is pulling upward, that will causing the, this is called true esophageal hernia. Next is the mix. The above condition most common is the it is a mixture of the type 1 as well as type 2. Here that means the short esophagus will present, as well the pulling of the stomach will also occur. And after that, most common of the paraesophageal variety start as a sliding hernia and progress to the include the body and the fundus, as here in earlier above case, in case of rolling hernia, only just upper or anterior stomach is pulling upward. Here part like fundus and the body of the stomach will also involve. Next is paraesophageal hernia containing other intra-abdominal organ. There is a most severe form, as here most serious on the all the above hiatal hernia. Okay, so here the sac contain either whatever the abdominal content, or like the organ spleen, colon, small intestine will be also pulled into the above to the diaphragm. Okay, so what are the clinical feature will be present? There may be also if the stomach is pulled upward, then symptom like heartburn, synthesis or secretion of the gastric juice will impaired, causing the heartburn, or epigastric or chest pain. Dysphagia may also occur, regurgitation or postprandial fullness will be occur, and the hematemesis as well the anemia will be also seen in case of the paraesophageal variety. These all are the symptoms that are directly causing in case of the our acquired hernia. So how we will investigate? Either by the barium swallow, endoscopy or manometry. Okay, it is barium swallow is the among the above, barium swallow is the most effective way to diagnosis, and after that endoscopy, mucosal erosion can also be seen. Okay, or manometry motility disorder, but it is not using currently. And after that, what are the complication will be occurring? In micro complication, there may be esophagitis or inflammation of esophagus will be occur. Remember, this is the one of the most important question for our MCQ point of view, that Cameron ulcer or riding ulcer occur in which condition? Okay, so Cameron ulcer or riding ulcer occur due to the constant abrasive force on the stomach as it rubs against the diaphragmatic hiatus and down with the respiration. Every as we know that there is a short esophagus is short, and so stomach is pulling upward. So for during every breath, respiration, there will be a rubbing of the stomach that will cause the ulcer in the stomach. Okay, that is also called a Cameron ulcer or riding ulcer. So how we will manage the case of the acquired hernia? So for the management, first, as we have the most common here, if you will look at the clinical feature, the most symptom are related to our acidity, like or due to secretion of the gastric juice, that is heartburn, as well the epigastric pain and dysphagia, regurgitation, above all are due to the acidity, okay, or secretion of the gastric juice. So for that management, we will go with the acid reducing agent will be given, and after that, after decreasing of the secretion, we will go for the surgery. So when the surgery is indicated in case of the all the paraesophageal hernia and hernia with a narrow opening with interruption of the barium swallow. Even if barium swallow is interrupted, then we will also go for surgery. So principle of the surgery, how we will what we will do in surgery, there will be excision of the sac to be done, and the mesh is placed if defect is more than the 8 centimeter. Okay, or also cruroplasty, where the crura are tied together. In this method, diaphragmatic crura are sutured together to prevent the migration of the G junction into the thorax and the resultant post-operative GRD to be done. Okay, approach will be obviously transabdominal, or either open or laparoscopic method is used over the transthoracic. Remember, transthoracic will be little tough, so we will go for the transabdominal method. So just simply we can look in this diagram, like this is our diaphragm part. Here we are. It is our coronal section. Okay, so this is our diaphragm. This is our anterior part. This is our anterior crura, and this is our posterior part. These are the lateral part. Okay, so what will happening that our the esophagus part is as crossing through this, like so. What we will do that from here we will tie the above two crura such that this part will be fixed inside, so that the G junction will not move and fixed here. Okay, that will be done. And after that, sliding inguinal hernia. Okay, in case of sliding inguinal hernia, when the part of the wall of the sac is formed by the viscous, the hernia is class sliding hernia. Okay, viscous, that means the our viscera or abdominal organ. So if the organ is present, then we call it sliding hernia. It occurs in 2 to 5% of all the indirect inguinal hernia. Okay, how its pathophysiology, as the age increase, there is increase in the intra-abdominal pressure, and or also obesity is also a risk factor, as they lead to laxity of the tissue. So as the retroperitoneal connective tissue became infiltrated with the fat as well the muscle, and the fascia became weaker, causing the with the age and the posterior parietal peritoneum advance through the ring. And remember what you have to remember is we will summarize it again, so once again. And also a loop of the bowel, even the medial lip of the mesentery may slide through ring and from the posterior wall of the hernial sac. Okay, simply we will recall it. First, what will happening here, as the age increase, there is increase in the abdominal pressure, as well in the obese person also there is increasing in the abdominal pressure. So okay, after that the retroperitoneal connective tissue infiltrate with along with the fat, causing the fascia to be weak, and if the fascia became weak, then the posterior parietal peritoneum advance through the ring, and the content like the loop of the bowel or mesentery will be slide out from there. Okay, next is our what are the organ involved. Okay, so obvious in right side, what are the organ present in our right side? That are the cecum, ascending colon, appendix, appendiceal mesentery, or the terminal ileum, and the mesentery of the terminal ileum are present, whereas in the left side there will be sigmoid colon, or from the both side we remember our common organ like ovarian fallopian tube or urinary bladder may be also seen through the posterior wall. Okay, what are the clinical feature? It is the more common in the male in the left side, and the hernia are the long duration, usually reducible, and a low incidence of the intestinal obstruction is seen. And a diagnosis, a large hernia of the long standing in the elderly patient should cause the suspicion of the sliding hernia. In the barium, enema may reveal the colon outside of the abdominal cavity, and the diagnosis will be made on at the operating table. Then how to be it would be managed. Okay. Next is the treatment. For the accurate diagnosis of the sliding inguinal hernia, usually it is not made until the sac is opened, because after opening we will know it properly that what the actual, and based on that surgery to be decided. Okay. What are the aim of our surgery? To peritonealize the extraperitoneal herniated organ, so that reverting back the organ, or what are the content of the herniated organ should be revert back to its normal position. Okay. So for that two approaches done. First is the intra-abdominal, or that is called a Leroc, or inguinal, that is called a Zimmerman or Lofman. Okay. So what is done in the Leroc technique, also called a intra-abdominal approach, in which the peritoneal cavity is entered above the internal ring, allow the accurate definition of the pathology anatomy, and as well the effective repairment of hernia. But it should be used in all the sliding indirect hernia. Okay. Only for the sliding indirect inguinal hernia. And inguinal approach is to be done in case as Zimmer and Lofman described, placing a persisting suture above, that we done in our process of appendectomy. Okay. Persisting suture to be done about the neck, or around the neck of the extending as the high of the anterior surface as possible on the posterior surface, as close is safe to the reflection of the peritoneum on the colon. We will just tie there the same above to the colon, and as the purse string is pulled together, the bowel is turned upward, and the close is sac. Okay. The sac and the bowel are reduced to the abdominal cavity and the transversalis fascia, and then it is closed snugly about the cord, and the reconstruction of the internal ring. Okay. This is all about our completely about diaphragmatic hernia. We will just summarize the above in slightly little detail. This is our revision part. So first what we study about diaphragmatic hernia. It is of two type, that is acquired and the congenital, where the congenital is again two type, Bordlake and the Morgagni. And after that we remember by the trick BPL, that is Bordlake, occur in the posterior and the left part. Etiology is due to the failure of the defective closure of the peritoneal canal, and the pathophysiology due to the pulmonary hyperplasia may be seen. Or after that clinical feature is our mnemonic RDS, that is respiratory distress, cardia, and the scaphoid abdomen. For investigation, prenatal USG and the chest X-ray, bowel to be done, and the pneumothorax. For treatment, first we will operate the during the birth of the baby. We will not cut the umbilical cord for a period of half hour, and during that we will check and as well the manage the condition. Okay. Manage the first we will respiratory, or if required then ECL is to be also given. And operative method, where the either excision or the reverting back of the organ will be done. Prognosis factor totally depend upon the pulmonary hypoplasia, as well the pulmonary hypertension. Other factor like extra diaphragmatic anomaly may also be seen. And after that we study the acquired diaphragmatic hernia. It is of four type. In sliding, just only movement of the stomach will be done, and after that in the rolling type there will be upward movement of the stomach, interior part will be done. In mixed diameter type, above the two are occurring along with the movement of stomach, that is fundus and the body of the stomach. And in paraesophageal hernia containing the internal organ, this is the most severe or serious type. The clinical feature include all the feature of our simply we can remember by the acidity, that is our heartburn, epigastric pain, dysphagia, as well the regurgitation, and the postprandial fullness. Hematemesis, if hematemesis occur in the larger amount, then the anemia may also be occurred. And for that investigation we will go with barium swallow, endoscopy, or manometry. Complication is esophagitis. The most important MCQ we studied here, that are the Cameron ulcer and the riding ulcer occur due to the constant abrasion force on the stomach as it rubs against the diaphragm in the hiatus. Okay. So for the medical management, we will reduce acidity and go for the surgery. First we will check the above from the barium swallow. Okay. And the principle of the surgery is the placing a max if the size is more than the 8 cm, or either chloroplasty will be also done by the transabdominal approach. And for the sliding hernia, viscous or the viscera organ is putting back. The main pathology is due to the increasing in the laxity of the tissue. There will be infiltration of the fat occurred in the fascia, causing the weakness of the same. and resulting in the posterior parietal peritoneum advance through the ring. And for that we will other organ are involved, like from the right side there may be cecum, appendix will be, and from the left side sigmoid, and from in case of bilateral ovary fallopian tube or bladder will be seen. For the clinical feature, it is more common will be on the left side, occurring in the male, and for the in case of long duration usually may be reducible but may cause intestinal obstruction. For diagnosis, same will be barium enema will be given, but for the case of method of the surgery will be decided based on the after opening we will select the method of it will do for the treatment. Okay, so aim of the surgery is there will be two approach, that is Lorek approach as well the Zimmer and Lobman. For the Lorek approach, peritoneal cavity is entered through the internal ring. Okay, and we will make the choice there to how the surgery how the opening will be closed. And in case of the inguinal or inguinal approach, that is called as Zeman or Lofman approach, here we will go for the persisting suture and tie the herniated content along with the bowel, so that the movement of bowel will occur resulting in the closure of the sac. This is all about our hernia. Thank you and have a good day. Next topic we will go for that is our portal hypertension. Okay, in case of doubt you may ask. Thank you, have a good day.